Thank you very much. It's such a pleasure to be here. Thank you. Excellent. So, as mentioned, I am a vascular surgeon at Mass General and associate professor at Harvard. And my specialty, I do carotids, aortas, everything, but really my love is limb salvage. And so we run the limb evaluation amputation prevention program, and ALI patients do come directly through us. So acute limb ischemia is a serious problem, regardless of whether or not it's the blood or it's the clot that's causing our issues. Obviously, someone stabbed in the groin that's bleeding out is a very different type of acute limb ischemia than a patient that has thrombus. And, we say that amateurs are afraid of arterial bleeding and people who are pros are afraid of venous bleeding. In the same way, amateurs are afraid of just hemorrhage, but pros are afraid of clot because that's what really knocks off those legs. So this is the magic number, 30%. 30% of people who come in with acute limb ischemia, regardless of what the cause is, bleeding, hemorrhage, or clot, even from, that causes phlegmasia, 30% of them will get amputated. You may get through the night, but the leg is gone because the muscle is dead or the nerve is gone, and ultimately you end up cutting the leg off. So it's a serious problem. And in the same way that when we have a ruptured aortic aneurysm, you want an algorithm in your mind so you're not wasting time and the patient doesn't die because you didn't have the right balloon or catheter or didn't image correctly. You want this for ALI as well. It shouldn't be something where it's like 50 first dates and you're doing, brand new thinking every time somebody walks through the door. You want to have an algorithm. So that's what I'm going to share with you today, what mine is, and it is all encompassing, so feel free to take it. So to begin with, when you have a patient that has acute limb ischemia, assuming it's not from hemorrhage, so we're talking about the clot, the bad one, there are two ways usually that people present. Either they've got embolic disease or they've got thrombotic disease. Embolic obviously came from somewhere, usually the heart. Somebody, getting their teeth cleaned, the dentist stopped their Eliquis for a couple of days and bang, they throw an emboli. Why does it matter? It matters because what the type of clot is going to be like. When we pull it out of the patient, when it's embolus, it's more like a piece of chewing gum. And that's dangerous because sometimes with a penumbra or something that you may go to just always as your thing, you can push or fracture that piece of chewing gum more and cause, as you know, distal problems with the foot. Now, if it's thrombus, that's the best stuff. That's the jello, and that penumbra would be great for. So it is important to get a sense of where you think it may be from. I won't insult your intelligence by going through the 6 Ps in the sense that a patient turns up with these different issues. Obviously, they have pain, pallor, pulselessness, but what really matters is how they get classified. So this is the first step. Patient comes into the ER, and really what I care about is the motor versus sensory loss. Why does it matter? If a patient comes in and they have sensory loss but not motor loss yet, that's a person that I can screw around with a little bit longer. As in, I can go to the operating room and I don't have to come out with a definitive repair. So I can go to the operating room, I can put in a thrombolysis catheter, let it sit for 24 hours, and come back a day later, and hey, if it didn't work, then sure, I take them back and I do an open thrombectomy or I do something mechanical to end the procedure with a flowing vessel. But if the patient turns up with sensory and motor loss, no time for jacking around. You've already wasted a lot of time in their transit and this and that, and you must leave the operating room with a definitive result. So you can put TPA down, but you have to do something to really show that you've got flow all the way through. This is a highly litigated space as well, so it's very important, if a lawyer were to say, oh, doctor, the patient came in with the ankle not moving, and you put a lysis catheter in, you would be hit with a lawsuit, that they could potentially win. Why does it matter? It matters because it speaks to how long the leg has been ischemic. The longer the leg's ischemic, the more motor loss and sensory loss you've got, up until the point where it's type 3 and you really have to think about primary amputation. I do that very rarely. I'll always give it a shot, but I'm pretty quick about it because what I don't want to do, and I've done this once before, took a patient who essentially had a dead leg, revascularized it, and then ended up killing her because I now released a bunch of potassium into the bloodstream in a dead leg, and our anesthesiologist couldn't appropriately catch up with that. And had I just primarily amputated, that probably would not have happened. So just something to keep in mind. Now, from a diagnostic standpoint, physical exam number 1, I'm not telling you to go and find out what the name of that patient's cat is, but you need to know motor sensory loss at that time and for how long. A lot of these patients, especially with the emboli, will tell you, oh, last night, my leg started to ache, and then I went to bed, and then I woke up, and it's been 13 hours by your calculation. That's someone that needs something definitive done. Of course, the ABIs will be 0. There's no worry. There's sometimes I've heard this before. People get worried if I do cuffs on there, I'll squeeze the clot out more. That's all fake news. None of that would happen. And then you get a CTA quickly. That's really mandatory. You have to know where the clot is. You don't want to get stuck with, oh, I have a femoral pulse, and therefore things must be okay, up to that point, because you can get a femoral pulse if your iliac is occluded, but your internal is still flowing. Or if they've got some, disease and they've got collaterals, like that's kind of olden days stuff now. CTA is really mandatory. And then, of course, you can take them for that angiogram. Just talking now a little bit about the actual management. So it depends on the patient, depends on the clot, and depends on where it's located. Now, we've got multiple options. I'm just going to break it down by, you've got pure thrombolysis. You put a catheter down and it takes the clot away by melting it essentially. And, you're heparinizing the sheath, you're heparinizing the patient, and you're dripping usually 1 milligram of TPA per hour. You have mechanical thrombolysis where you physically go and remove the clot, but it's all endo. And then you have Fogarty embolectomy, which is a cut down and removal of the clot. Works beautifully for like common femoral, SFA, even profunda. Kind of crappy for the tibials. Surgeons will tell you, I just cut down on the tibials and you throw the balloons up there. No, you don't. You end up spasming those vessels, and you certainly can't do that for the pedal. So you're ending up doing all these cuts and then putting a lysis catheter down anyway. Not great. So if you can do everything endo, that is ideal. But you, as I said, have to make that decision based on whether or not they had sensory or motor changes to begin with. I am happy to share this talk. I've done it in a way such that I actually have the steps for each thing, if anyone wants them, especially for the fellows. Obviously won't go through that. But basically for an open embolectomy, and I make this decision based on the fact that the patient had potentially an embolus from the heart. Because in that case, you can just go and cherry pick the embolus right out of where the profunda and SFA take off. And that's that horrible gummy stuff. But then they've probably thrombosed fresh clot into their SFA and down. So I can embolectomize all of that open. That way, I'm not shoving a penumbra or some sort of mechanical device and kind of jamming that piece of thrombus that came from the heart deep into the patient's vessel. So that's the logic there, and that's usually the most common reason why I do open embolectomy. You guys all know catheter-directed thrombolysis. I like ECOS, but my nurses don't because, again, as I said, 50 first dates with that, and I don't have time at 2 a.m. So the Craig McNamara is my boyfriend at night when I don't have anything else to put down, because that's easy. Long segment, shove it in. You must cross the clot. So you cannot just leave it at the top and hope it drips down. Of course it doesn't. The patient is flat. So you do have to put it all the way through and make sure that you get your lysis catheter down. Label everything for those nurses, or they, So the other thing is the fibrinogen levels. This is a bit controversial. Not everyone does it. I do it because I don't want to get sued. We are in New York. That's a thing you guys do here too. And so, if you get those fibrinogen levels, you know that if it drops greater than 50%, you probably have to cut back on the TPA about half. And if it drops more than that, you should just shut it off. But make sure they don't shut off the heparin going through your sheath, or you'll thrombose off the same thing all over again. You guys do know about penumbra. Of course, we just had a beautiful talk on that. Usually for penumbra, I like to use, now I'm using the bolt that they now have because it fractionates and sucks. But I like to use the Lightning. That's what I've been using all these years. And usually the 6 is what I'll put down, sometimes even a little bit bigger. But be careful with the penumbra and the arterial segment because it can dissect, especially because you can imagine big circle, little wire in the middle. It can dissect quite aggressively if you're not careful. Angiojets, the old school. There's some new stuff now on the market. Jetties come out. So basically anything you have available is okay. There's no thrombolysis device that's wholly amazing and better than something else. But really how comfortable you are and your nurses are is what determines what you end up using. Now we're talking about acute limb ischemia. This is the other drama that acute limb ischemia can be caused by, which is venous in nature. So phlegmasia, it's real. It happens about 3-4 cases a year at least we get. And in these patients, you must decompress that vein and potentially get into the arterial circuit because that may all be thrombosed off as well. You don't know. At this point, you know the vein caused so much thrombus that it shut off the arterial circuit, but you don't know if this person's arterial group is also completely occluded. They can present 2 different ways. The pregnant woman is really the scary one because that's where really I just esmark them and I'm doing an open cut down. You can, shield them appropriately and do things with pregnancy as well. But at 2 a.m. in the morning, this is just an easy thing to do as long as they're not very gravid and you can get into that groin. And you have a definitive result. This is another area where you wouldn't want to screw it up. You really want to make sure you leave the operating room with the leg completely revascularized. This is one of our... we didn't do the study, but this is one of the ways in which we like to go ahead and get that clot because it really nets everything in one hit. You guys all must have heard of the Attract trial as well that is talked about not needing to do this, which is true in patients that don't have phlegmasia, obviously. In that case, you must go and you must get the clot out. And quite frankly, I mean, even if I had a big clot, I'd want it removed. So the Attract trial doesn't help me much because I don't want that post-thrombotic syndrome that's happening to me 10 years from now where my leg now gets ulceration. So if you have a patient that has a large iliofemoral DVT, it is an appropriate thing to go ahead and use the clot retriever. Basically what it does is go in, net the entirety of the clot and yank it out. Hopefully not fractionating, not going to cause PEs, but you can always drop a quick IVC filter from the neck and just take care of business if you're worried about that. And of course, as you know, a decent amount of stuff comes out, the kind of fresh clot here and obviously the stuff that's been there for a while. Now, I just want to end with lastly saying you cannot talk about acute limb ischemia without talking about fasciotomy. Fasciotomy must be done on patients because this is a patient that got shot in the leg.
Go ahead and move your
and
ankle
you can just hear, watch this. So that's the leg that was shot.
Press up on me. Okay. And then press down. Okay, so pressing down is good. And then what happens if I move up here?
Ah!
Does that hurt you?
Yeah.
So if I press like this,
Shot
that's
right
okay?
here.
Yeah.
Okay.
No
and
problem.
This movement right here.
Ah!
Wow, okay.
Yeah, wow is right. So that's the response that you should have too. Wow, this guy's screaming way more than they should be for just a little movement. That guy goes to the operating room now. And then, of course, in terms of the fasciotomy, you can see here, so muscle's not supposed to look like that. Muscle looks like Barbie pink. That's not Barbie pink. And it bulges out. And so you need to make sure that that fascia is actually nicely opened so that you can fully ensure that the muscle is released. This is one of the most litigated aspects as well of surgery, not doing a complete fasciotomy. And the key is you must, on the medial side, get your finger on the tibia, slide it up and down so the soleus leash is actually released, or you're not in the deep compartment. Somebody like this with a big, thick muscle, you'll miss it so easily. And by the time you get to them the next morning, muscle is dead, leg is essentially dead. So I just show again, I won't go through, hours of this, but just pointing out, look at that muscle bulge. And already, look, is showing the color that if we hadn't released it, we would have had a serious problem. If the patient is passed out in the ICU and you can't do anything to determine whether or not they have a physical exam, the Stryker needle is the way to go because you can actually stick it in the compartment. If it's greater than 30 millimeters of mercury, you know that that's way higher than it should be. And that's a patient that needs to have a fasciotomy done. Post-operatively, after ALI, you must ensure that the fasciotomy was complete, so monitor that CK. It will bump a little bit after you're done into the thousands, but then it should come down after 2 checks. If it's not, you've got an incomplete fasciotomy. You also have to ensure that the patient gets anticoagulated appropriately and that they're being appropriately hydrated so that you get all of the rhabdomyolysis out of their body so that it doesn't go to the heart or destroy those kidneys because otherwise they get ATN. Thank you very much for your time. I appreciate it.